In this video, we are going to discuss about a gynecology topic called endometriosis and adenomyosis. In the part 1, we'll be dealing with endometriosis, and in part 2, adenomyosis. The contents of this video: endometriosis, the definition of endometriosis, sites, pathogenesis, clinical features, diagnosis, differential diagnosis, and complications of endometriosis. Let us start with the definition of endometriosis. The presence of functioning endometrium, glands and stroma in the sites other than the uterine mucosa is called endometriosis. So, when the functioning endometrium, the innermost lining of the uterus, which is supposed to be found in the uterine mucosa, when it starts appearing in the other sites, then it is known as endometriosis. It is not a neoplastic condition, although malignant transformation is possible. They are saying it is not a neoplastic, it is not a cancerous condition, but it can turn out to be malignant. So it can turn out to be cancerous at some times. More commonly, however, these tissues are found at the sites other than uterus and are called endometriosis externa, or generally referred to as endometriosis. So they are saying whenever these sites are found, the endometrial tissue, it is found at the sites. When the endometrial tissue is found at the sites other than the uterine mucosa, if it starts appearing in the ovaries or the fallopian tubes or the ligaments, then this is known as endometriosis externa, or simply known as endometriosis. Endometriosis is a disease of contrast. It is a benign, but it is a locally invasive, disseminates widely. So they are saying endometriosis, there are two contrasting points. One, it is a benign condition. Benign condition means it does not invade the tissues, it is not invasive, nor it spreads to the other parts. But here, the endometriosis is invasive. Locally, it is invading the tissues. It is locally invasive. It is disseminating widely, which means it is spreading widely. So these are the two contrasting points. One, they are saying it is benign. At the same time, endometriosis is invasive as well as spreading widely. Cyclic hormones will stimulate the growth, but the continuous hormones suppress it. The cyclic hormones, which are released by the pituitary gland during each menstrual cycle, that is estrogen. This cyclic hormone is going to stimulate the growth of the endometriosis. The hyperestrogenic state is responsible for the growth of the endometrium. However, if there is a continuous growth, continuous secretion of hormones, the growth is suppressed. The sites of endometriosis are abdominal, extra-abdominal and remote. Abdominal, it can occur at any site, but it is usually confined to the abdominal structures below the level of umbilicus. So the endometriosis can occur at any site, that is in the legs, arms, brain, lungs, any site, but it is more usually confined to abdominal structures which are found below the level of umbilicus. Extra-abdominal. The common sites are abdominal scar of hysterectomy. So extra-abdominal comprises all the types of scars. They are the scar of hysterectomy. Hysterectomy, the surgical procedure done for the removal of uterus. Caesarean section, the scar which is left on after caesarean section. Endometriosis can take place at this site. Tubectomy, the surgical procedure where the fallopian tube, a part of it is cut and it is tied up. Myomectomy, the surgical procedure done for the removal of uterine fibroids. Umbilicus, so the extra-abdominal site, endometriosis can occur at the umbilicus. Episiotomy scar, a surgical cut which is given during the childbirth for the easy delivery. Vagina and cervix, these are the extra-abdominal. They are the scars of hysterectomy, tubectomy, myomectomy, episiotomy, caesarean section, umbilicus, vagina and cervix. The sites of endometriosis, let us summarize them. The common sites are ovaries. The topmost site for endometriosis to occur is ovaries. Pelvic peritoneum, pouch of Douglas, Pouch of Douglas. What is pouch of Douglas? It is a deep peritoneal space or a recess which is found between the uterus. So the uterus is in the between. Then the space is found between the uterus and upper vaginal wall anteriorly. Posteriorly, what do we have? Rectum. So it is a space which is found between the uterus and anteriorly vagina, posteriorly rectum. Uterosacral ligament. You see, uterosacral ligament is a connective tissue which is found between the uterus and the sacrum, the lower part of the spine, sacrum. This connective tissue, in this connective tissue, the endometriosis can occur. Rectovaginal septum, again this is also a connective tissue which is found between the rectum and the vagina. Sigmoid colon, appendix, pelvic lymph nodes, fallopian tubes. These are the common sites. Now we'll look into the rare and the remote sites. They are umbilicus, abdominal scar, episiotomy scar, lungs, pleura, ureter, kidney, arms, legs, nasal mucosa. These are the rare and remote sites. The rarest sites like nasal mucosa and remote sites lungs, pleura, ureter, kidney, arms, leg, episiotomy scars, abdominal scars and umbilicus. Now we'll look into the picture. You can see the cul-de-sac, that is nothing but the pouch of Douglas, the space anteriorly vagina, posteriorly rectum, then rectum, uterosacral ligament. You see here ovaries here, and then uterosacral ligament which is found here, the pouch of Douglas, the space between the anteriorly vagina and posteriorly the vagina, and posteriorly there is rectum, and then here broad ligament, the scar, rectovaginal septum, the vagina, and this is rectum. So the space the connective tissue, rectovaginal septum. Now here continuation. Pathogenesis still remains unclear. We do not know the pathogenesis. It is still unclear, but are full of theories. But a number of theories have been proposed. The principal ones are, so some of the principal theories are stated below, that this could be the cause for, this could be the pathogenesis of endometriosis. Retrograde menstruation, also known as Sampson's theory. This is most widely accepted theory. 70 to 80% people accept this theory. 70 to 80% of the endometriosis is because of this. This is what the theory says. There is retrograde flow of menstrual blood. So retrograde, when it is in the opposite direction. So the normal flow endometriosis, the shedding happens from the genital tract vagina, but when the endometriosis, when it starts transversing upwards in the opposite direction, when it starts going in the opposite direction, reaching the fallopian tubes, ovaries and all, this is known as retrograde flow through the uterine tubes, that is fallopian tubes, during menstruation. There is retrograde flow of the menstrual blood through the uterine tubes during menstruation. The endometrial fragments get implanted in the peritoneal surface of the pelvic organs. So guys, when they are transversing upwards, what happens? These endometrial fragments, these small pieces of the endometrium, they get implanted in the peritoneum of those pelvic organs. The dependent sites will be ovaries, uterosacral ligament, etc. As a result, what happens? There is a cyclic growth and the shedding of the endometrium at these ectopic sites. They occur under the influence of the endogenous ovarian hormones. Like as I told you in the previous slide, what happens? The cyclic hormones, that is the pituitary gland, is going to secrete the hormones during menstruation. These hormones are going to cause the growth and shedding of the endometrium, which is located at the different sites. While this theory can explain the pelvic endometriosis, now we can imagine the retrograde flow of the menstrual blood to the fallopian tube to the ovaries. This is imaginable. We can think it can flow back to the fallopian tubes and then to the ovary. But can you imagine the menstrual blood flowing to the brain? It is going into the nasal mucosa. This is not possible with this theory. So this theory can explain the pelvic endometriosis, but it fails to explain the endometriosis at the distant sites. The pleura, lungs and all cannot be justified with this theory. So it is just a proposition, it is not accepted. Next we move on. Coelomic metaplasia, also known as Mayer and Ivanhoff theory. Coelomic metaplasia. Guys, what is coelomic cells? The coelomic cells, these are the cells which transform into the peritoneal cells and the surface of the ovary. These are the cells which form the peritoneum and surface of the ovary. Instead of forming these cells, when they start to grow into the endometrial tissue, see, there is metaplasia. What is metaplasia? When a well differentiated cell type is transforming into the another well differentiated mature cell. So the coelomic cells, instead of becoming the peritoneal cells or the surface of the ovaries, they become into the endometrial tissue. Then this is known as coelomic metaplasia. Now let us see what the theory says. Chronic irritation of the pelvic peritoneum by the menstrual blood may cause coelomic metaplasia. And what is the reason for this transformation of the cell? The chronic irritation of the peritoneum by the menstrual blood will be the cause for the coelomic cells to metaplase, which results in endometriosis. So the coelomic cells are transforming into endometrial cells here. Alternatively, the Mullerian tissue remnants may be trapped within the peritoneum. Alternatively, or another way, what happens? The Mullerian tissue remnants can also be trapped in the peritoneum. Two things can happen. The menstrual blood can cause the chronic irritation and it can cause the transform of the coelomic cells into endometrial tissues. Then other thing what can happen? The Mullerian tissue remnants can be trapped in the peritoneum. They can undergo metaplasia and be transformed into endometrium. Even the Mullerian tissue remnants which are trapped in the peritoneum, they also undergo metaplasia and they can be transformed into the endometrial tissue. This theory can explain the endometriosis of the abdominal viscera, the rectovaginal septum and the umbilicus. With this theory, the coelomic metaplasia, three things can be justified: the abdominal viscera, the endometriosis of abdominal viscera, rectovaginal septum and umbilicus. Direct implantation. What this theory says is, according to this theory, the endometrial or decidual tissue starts to grow in susceptible individual when implanted in the new sites. So people who are susceptible for endometriosis, either it could be genetic, first familial inheritance, or if they are low immunity. So people who are susceptible to endometriosis, the endometrial or decidual tissue, it starts growing where it is implanted. Wherever in the new site it is implanted, it starts growing. Such sites are abdominal scar following the hysterectomy, caesarean section, tubectomy and myomectomy. We saw in the rare and remote sites, in the extra abdominal sites, the scar, caesarean section, tubectomy, myomectomy. What is the cause for it? The people who are susceptible, the endometrium goes, deposits in these sites and it transforms into the endometriosis. Endometriosis at the episiotomy scar, vaginal or cervical site can also be explained with this theory. Again, this is also scar, so people who are susceptible to it, the endometrial tissue deposits and it turns out to be endometriosis. This theory, however, fails to clarify endometriosis at the sites other than the above mentioned. So, the direct implantation, it can justify these things, the extra abdominal sites, but it cannot justify the other sites other than the episiotomy scar, hysterectomy, caesarean section, abdominal scars, myomectomy scar, and then vagina, cervix. Apart from this, it cannot justify the other sites. Lymphatic theory, halban. Lymphatic theory by halban. What he says, it is possible for the normal endometrium to metastasize the pelvic lymph nodes through the draining lymphatic channel of the uterus. You know, metastasize, it is different from metaplasia. Metaplasia is when the differentiated cell transform into another cell. Here they are saying metastasize. Metastasis is the spread of cancer cells from the origin to the other parts. So the endometrial tissue, which is malignant in nature, can drain through the lymphatic channel, then reach the lymph nodes and cause the endometriosis of the lymph nodes. This could explain the lymph node involvement. So we understood how the lymph node undergo endometriosis. What happens? The endometrial tissue, it starts metastasizing and then it reaches the pelvic lymph nodes through the lymphatic channels. Vascular theory. This is sound at least to explain endometriosis at the distant sites such as lungs, arms or thighs. So to justify the distant sites such as nasal mucosa, lungs, arms, thighs, brain and all, what we can do, we can think of vascular theory. Vascular is via the blood. So the endometrial fragments can be transformed from the blood, they can be reached to the lungs and arms or the thighs, at the distant sites they can be reached. Genetic and immunological factors. The genetic basis of endometriosis probably accounts for less than 10% of the patient. Genetic basis, that is inheritance is less than 10%. There is 6 to 7 times increased incidence in the first degree relatives. So the first degree relatives, there is an incidence of 6 to 7 times it can be increased. However, a defect of local cellular immunity may be responsible for the ectopic tissue to grow in abnormal sites only in susceptible women. However, if there is a cellular immunity, if the immunity is very low in people, it is responsible for the ectopic tissue to grow in the abnormal sites. We already saw the direct implantation, it was in the susceptible people who had low immunity. Peritoneal macrophages normally remove the menstrual debris by phagocytosis. So what happens in the people who have high immunity, if the endometrial tissue is deposited in the other sites, what happens, it will be considered as a foreign body for that site and it will be phagocyzed by the macrophages. However, in the people who have low immunity, the macrophages won't work, phagocytosis does not happen, they become susceptible to endometriosis. This is immunological factor. In patients with endometriosis, the activated macrophages secrete several factors like cytokines, interleukin-1, alpha tumor necrosis factor, integrins. These factors will promote the growth of endometrial cells over the ectopic sites. Whereas in the people who are immunologically deficient, what happens in them, the macrophages is going to secrete the cytokines like interleukin 1, tumor necrosis factor and integrins. What these cytokines do is they are promoting the growth of the endometrial tissue. Instead of phagocytosing it, considering to be a foreign body, that does not happen here. Instead, there is a growth of the endometrial cells over the ectopic sites under the influence of the cytokines which are released by the macrophages. Environment theory. It suggests somatic mutation of cells due to the environmental factors. So guys, somatic mutation. Somatic mutations are the changes in the DNA which is occurring after the conception. It is due to the environmental factors such as pollutants, dioxins. Ovarian and deep infiltrating endometrial lesions are explained with the environmental theory. With this, we come to an end of all the theories. Hope it is clear. Let us summarize it once. We started it with retrograde menstruation, also known as Sampson's theory. What happens here? There is a retrograde flow of the menstrual blood. It reaches the fallopian tubes and then to the ovaries. Then there is a cyclic growth of these ectopic endometrium and there is shedding occurring. Then we studied about the coelomic metaplasia. Two things happen here. One, the coelomic cells are transformed into endometrial cells and there is shedding. Then the Mullerian remnants can be trapped by the peritoneum and this can also undergo metaplasia and transform into the endometrium. Then we read about the direct implantation. People who are having low immunity, the endometrial tissue gets implanted in the extra-abdominal sites such as scars, vagina, cervix, cesarean section and so on. Then we read about the lymphatic theory. What happens? There is metastasis happening. The endometrial tissue, the malignant endometrial tissue, it is invading the lymphatic channel and then reaching the lymph nodes. In vascular theory, we read about the distant sites. The endometrium via the blood, it is reaching the distant sites. Genetic and immunological factors. Genetic, it is 10% in, it is accounts for less than 10%. 6 to 7 times it is increased in first degree relatives. Then we read about the immunological factors. What happens? People who have low immunity, the macrophages do not phagocyte. Instead, the release cytokines such as interleukins, tumor necrosis factor alpha and integrins. These cytokines are going to promote the growth of the endometrium over the ectopic sites. Then we read about environment theory. There is genetic mutation, somatic mutations of the cells. DNA is being mutations happen there. there is changes happening, which leads to the ovarian and deep infiltrating endometriotic lesions. Theories to explain the endometriosis at different sites. The pelvic endometriosis was explained by retrograde menstruation. It is just a revision. With this, we can get a clear clarity about how the different sites and then what theories they are proposed, what could be the cause for it. Pelvic endometriosis, the cause could be retrograde menstruation. Pelvic peritoneum, coelomic metaplasia. Abdominal viscera, rectovaginal septum, umbilicus, again coelomic metaplasia. We saw the abdominal scar, episiotomy scar, vagina, cervix. These are all extra abdominal sites. What did we learn, guys? It was via the direct implantation. Lymph nodes, lymphatic spread. The distant sites such as lung, pleura, skin, lymph nodes, nerves and all, it is vascular spread. It can also be genetic and immunological. With this, we come to an end of theories. Now we are going to study about the clinical features of pelvic endometriosis. Patient profile. The age is between 30 to 45. So the women who are aged 30 to 45 are more susceptible. The patients are mostly nulliparous or have had 1 or 2 children. Nulliparous, which means they have not bared any child, or they might have 1 to 2 children long years prior to the appearance of symptoms. Before having endometriosis, long years back, they might have had 1 or 2 children. Infertility, voluntarily postponement of first conception until a late age, and higher social status are often related. So infertility, voluntary postponement of first conception, voluntarily they are postponing the first conception due to some reasons, and also the higher social status are often related. So endometriosis is common in the higher social status people. This is the patient profile. 30 to 45 years, nulliparous or 1 or 2 children, infertility, voluntary postponement of first conception and higher social status. Symptoms. About 25% of the patients with endometriosis have no symptoms. So guys, it is really hard to diagnose. 25% of the patients come with no symptoms, being accidentally discovered either during laparoscopy or laparotomy. So endometriosis might be accidentally discovered in 25% of the patients during laparoscopy or laparotomy. Symptoms are not related with the extent of lesion. So they are saying even when the endometriosis is widespread, that is, even though it is malignant, there may be no symptoms. However, with the intense symptoms, there might be minimal endometriosis. When there is more endometriosis, no symptoms will be found. When there is minimum endometriosis, severe pelvic pain and dyspareunia, dysmenorrhea. We are going to read the symptoms in detail in the next slides. So the intense symptoms with the minimal endometriosis is found. So they are saying the symptom is not related to the extent of the endometriosis. Depth of penetration. Lesions penetrating more than 5 mm is responsible for pain, dysmenorrhea and dyspareunia. So guys, the lesions which are penetrating deeper, you see from the muscles, they are reaching the nerves, then these deep penetrating lesions will be responsible for the pain. And dysmenorrhea is painful menstruation which is incapacitating the women's day-to-day activities. That severe pain is dysmenorrhea, and dyspareunia is a painful sexual intercourse. Non-pigmented endometriotic lesions compared to the classic pigmented powder burns lesions produce more prostaglandin factor and hence are more painful. So they are saying there are 2 types of endometriotic lesions. One is non-pigmented, the other one are classical pigmented, also known as powder burns or the matchstick appearance they give. These lesions are they produce more prostaglandins. As a result, they are more painful. The symptoms are mostly related to the site of the lesion. So you see, if it is occurring in the rectum, the desired symptoms like dyschezia and difficult passing of stools and as well as melena will be found. In the same way, whichever related to the site of the lesion, if it is found in the urinary bladder, dysuria, hematuria related to the site of lesion, the symptom will be found. Degree of the pain is not related to the severity of endometriosis. We saw there is no relation with the extent of the lesion, so even the pain is not related to the severity of endometriosis. So guys, in this slide we learned that it is 25% of the patients are asymptomatic. Then symptoms are not related to the extent of the lesion. The depth of the penetration when it is more than 5 mm, it is responsible for the pain and dysmenorrhea and dyspareunia. The non-pigmented endometriotic lesions, which are compared to the classic pigmented lesions, non-pigmented are more painful. Then the symptoms are mostly related to the site of the lesion and the pain is not related to the severity. Dysmenorrhea, 70% patients undergo dysmenorrhea during endometriosis. There is progressively increasing secondary dysmenorrhea. Pain is usually begin after few years pain-free menses. So guys, what is secondary dysmenorrhea? First there will be a painless menses and then they start with painful menses. So the pain usually begins after few years of pain-free menses. There is a pain-free menses, then again there is painful menses. The site of the pain is usually deep-seated and on the back or rectum. So the pain is situated on the back and on the rectum. Increased secretion of prostaglandin factor 2 alpha and thromboxane B2 from the endometriotic tissue is the cause of the pain. So guys, what happens in dysmenorrhea? There is a role of the prostaglandins for the cause of the pain. What happens is the prostaglandins will be synthesized from the secretory endometrium. These prostaglandins will act as a strong vasoconstrictor. Acting as a vasoconstrictor, they are going to cause the ischemia, angina of the myometrium. So, more increased production of the prostaglandin will result in more pain. So, the increased secretion of prostaglandin as well as thromboxane from the endometric tissue is the cause of the pain. How is this prostaglandins causing the pain? They act as a vasoconstrictor, cause the ischemia, angina of the myometrium resulting in pain. And where is the pain situated? It is deep seated on the back or rectum. Abnormal menstruation in 20% cases. Menorrhagia, that is excessive menstruation more than 80 ml or more than 7 days, it is a predominant abnormality. If the ovaries are also involved, polymenorrhea or epimenorrhea may be pronounced. Polymenorrhea when the cycle is reduced to less than 21 days, or epimenorrhea which means when the cycle is reduced to 21 days and on top there is excessive bleeding, then it is epimenorrhea. If the ovaries are involved, the person will have polymenorrhea, that is the cycles are going to be short, and epimenorrhea, cycle short plus excessive bleeding. There may be premenstrual spotting. So before the menses also there might be premenstrual spotting. Infertility in 40 to 60% cases. About 40 to 50% of the patients with endometriosis will suffer from infertility. Next. Dyspareunia. The dyspareunia is painful sexual intercourse. It may be due to the stretching of the structures of the pouch of Douglas or a direct contact tenderness. What happens here? There is a stretching of the pouch of Douglas. Where is the pouch of Douglas located? We read it in the previous slides. The pouch of Douglas, it is a space which is situated between the uterus and the anteriorly vaginal wall and posteriorly rectum. So there is stretching of the structures of the pouch of Douglas, or there might be direct contact tenderness during the coitus, and as such it is mostly found in endometriosis of pouch of Douglas and is fixed with retroverted uterus. So guys, when the endometriosis is found in the pouch of Douglas and there is retroverted uterus. Retroverted is when the uterus is slightly tilted backward instead of forward, then it is known as retroverted uterus. Dyspareunia, why is it there? When there is a stretching of the structures of the pouch of Douglas and the endometriosis is found in the pouch of Douglas and there is fixed retroverted uterus. This results in dyspareunia. Chronic pelvic pain. The pain varies from pelvic discomfort, lower abdominal pain or backache. So, the pain starts from It can vary. Either there will be pelvic discomfort, or sometimes there will be lower abdominal pain or backache. The pain aggravates during the period. There may be variable degree of abdominal pain. Now you are going to discuss about the abdominal pain. There will be variable degree of abdominal pain around the periods. Sometimes the pain may be acute. Why is there a acute pain? It is because of the rupture of the chocolate cyst. Chocolate cyst, it is found in the ovaries. When there is a rupture of the chocolate cyst of the ovary, there is acute pain of the abdomen. The other symptoms are urinary frequency is increased or decreased, dysuria, back pain, or even hematuria. Dysuria is painful urination, and hematuria. So guys, you see there is an endometriosis deposited in the ureter or the urinary bladder. What happens? It is going to obstruct. When there is obstruction, the frequency of urination will be reduced. There will be painful urination. When it is obstructed, then there will be obviously painful urination, backache, and even hematuria. Hematuria, why does hematuria happen? Hematuria is the blood in urine. What happens is during the cyclic growth of the endometrium during the menses, what happens? The endometrial tissue, which is like deposited in the urinary bladder, even it undergoes the growth and the shedding happens of those endometrial tissue as well. Then the blood will be found in the urine. Sigmoid colon and rectum. Painful defecation dyschezia. Again, the sigmoid colon and the rectum is obstructed by the endometrial tissue. So endometriosis occurring at these sites will result in dyschezia, diarrhea, constipation, rectal bleeding. So cyclic hormonal growth happens of the endometrial tissue, and there is shedding of these endometrial tissue resulting in rectal bleeding and even melena. Melena is blood in stools. Chronic fatigue, premenstrual symptoms, bowel bladders. So, the chronic fatigue and premenstrual symptoms are found. Hemoptysis rarely. Hemoptysis is a blood in sputum. Catamenial chest pain. So guys, when the endometrial tissue is located in a distant site such as lungs, during the cyclic menses, the hormones are released which are acting on the ectopic endometrial tissues, resulting in their growth and shedding. So even in the lungs, the endometrial tissue is going to undergo growth and it is going to shed, resulting in hemoptysis, that is blood in sputum, and catamenial, that is during the menses, chest pain is found. The surgical scars, cyclic pain and bleeding. Even in the surgical scars, whenever there is cycles happening, the hormones act, there is growth and there is shedding. Surgical scars also, there is cyclic pain and bleeding. Hope everything is clear. Why the blood is found in each of the symptom? Urinary, we saw hematuria. Each organ there is secretion of blood. Urinary, there is hematuria. In sigmoid colon and rectum, there is melena. And then in chronic fatigue, premenstrual symptoms will be there. In the chest symptoms, we saw hemoptysis. In surgical scars also, we saw bleeding. It is because there is cyclic growth of it under the influence of the hormones, pituitary hormones, and also cyclic shedding like as in uterus. Abdominal examination. A mass may be felt in the lower abdomen arising from the pelvis. So, during the abdominal examination, you can feel a mass arising from the pelvis in the lower abdomen. Enlarged chocolate cyst or tubo-ovarian mass. So, the mass is a chocolate cyst. You can see the ovaries which contain a chocolate cyst or tubo-ovarian mass. Tubo-ovarian mass, it is a mass which is found in the tubes and the ovaries. It is an abnormal growth of a tissue due to the endometriotic adhesions. The mass is tender with restricted mobility. So guys, what happens? The endometrial tissue, it is getting deposited in the ovaries, resulting in chocolate cyst and tubo-ovarian mass, and these are due to the endometriotic adhesions. The endometriotic tissue is getting adhered in these sites, resulting in chocolate cyst or tubo-ovarian mass. This mass is felt during the abdominal examination. The mass is tender with restricted mobility. You see, the mass is going to be tender, but it is with a restricted mobility. It is not moving. It is immovable. Pelvic examination. The expected findings are pelvic tenderness. When you do the abdominal examination, we saw a mass which is chocolate cyst or tubo-ovarian mass. Now here during the pelvic examination, what do we find? There is pelvic tenderness, nodules in the pouch of Douglas, nodular feel of the uterosacral ligament, fixed retroverted uterus, or unilateral or bilateral adnexal mass of varying size. Adnexal is ovaries and the tubes together known as adnexal mass. So there is variable sizes of masses found in the tubo-ovarian. The tubo-ovarian mass is nothing but the adnexal mass. So guys, what are the positive findings in the pelvic examination? There is tenderness, there is nodules in pouch of Douglas, there is nodular feel of uterosacral ligament, there is fixed retroverted uterus and tubo-ovarian mass. The diagnosis. Clinical diagnosis is by the classic symptoms of progressively increasing secondary dysmenorrhea. See, we saw the clinical features, the symptoms. Now, based on these symptoms, you're going to diagnose it to be endometriosis. If the patient comes with a progressively increasing secondary dysmenorrhea, dyspareunia, and infertility. These three classical symptoms, what are these? Dysmenorrhea, dyspareunia, and infertility. There is corroborated by the pelvic findings of nodules in the pouch of Douglas, nodular feel of the uterosacral ligament, fixed retroverted uterus, unilateral or bilateral adnexal mass. So guys, clinically, how are you going to diagnose it? First, the patient comes with three symptoms: dysmenorrhea, dyspareunia, and infertility. Then you do the pelvic examination. You find there is nodules in pouch of Douglas, there is nodular feel of uterosacral ligament, there is a fixed retroverted uterus, and there is a bilateral or a unilateral adnexal mass, which will give a justification that it is endometriosis. Serum marker CA125. A moderate elevation of serum CA125 is noticed in patients with severe endometriosis. So, a serum marker called serum marker CA125 is found high in patients who are suffering with severe endometriosis. Another thing called as monocyte chemotaxic protein MCP1, it is also increased in the peritoneal fluid of the women with endometriosis. So, to diagnose it to be endometriosis, two things: the serum marker CA125 and MCP monocyte chemotaxic protein. The monocyte chemotaxic protein and serum marker 125 are elevated in their levels in the women who are suffering with endometriosis. The imaging techniques. Ultrasonography is not of much helpful for the diagnosis. So ultrasound does not give much help to diagnose the endometriosis, whereas transvaginal ultrasonography can detect the ovarian endometriosis. You see, transvaginal sonography, we can detect the endometriosis here. You can see the matchsticks appearance. TVS can detect the ovarian endometriosis. Transvaginal sonography and endorectal ultrasound are found better for rectosigmoid endometriosis. So guys, when you do the endorectal ultrasound, it is for rectosigmoid endometriosis. Next, magnetic resonance imaging, MRI. MRI is a diagnostic tool. MRI is useful for deep infiltrating endometriosis. So MRI is also a diagnostic tool. We can use it as a diagnostic tool, and it is for the deep infiltrating endometriosis. CT scan is better compared to the ultrasonography in the diagnosis. So the CT scan will be of better use rather than the ultrasonography, USG. Colonoscopy, rectosigmoidoscopy, and cystoscopy are done when the respective organs are involved. So whenever the colon or the rectosigmoid and the respective organs, whenever they are involved, accordingly we do the colonoscopy, rectosigmoidoscopy, and cystoscopy. Laparoscopy is the gold standard. So mostly what do we do? Laparoscopy in endometriosis. This is the gold standard. So far we read there is the imaging techniques where TVS, transvaginal sonography, magnetic resonance imaging, CT scan, colonoscopy, rectosigmoidoscopy, cystoscopy. Now we come to laparoscopy. This is the gold standard. Confirmation is done by double puncture laparoscopy or by laparotomy. The other benefits of doing laparoscopy are confirmation of the lesion with the site, size and extent. So you can confirm the lesion, the site of the lesion, the size of the lesion and the extent of the lesion. The site, size and the extent can be confirmed by laparoscopy. The biopsy can be taken at the same time. So, while doing the laparoscopy, even the biopsy can be taken at the same time. The staging of the endometriosis can be done. The extent of adhesions could be recorded. We can assess the extent of the adhesion. Opportunity to do the laparoscopic surgery if needed. Then and there, if it is required, we can do the laparoscopic surgery as well. These are the benefits. 1. We can confirm the site, size and the extent. The biopsy can be done at the same time. Staging can be done. The extent of lesion adhesion can be recorded. And the laparoscopic surgery can be performed if it is required at the same time. The classic lesion of pelvic endometriosis is described as powder burns or matchstick spots on the peritoneum of pouch of Douglas. So guys, the classic lesion, when to confirm it to be pelvic endometriosis, when you do the laparoscopy, there is a classic lesion of a powder burn or matchstick spots. You can look in the picture here. The powder burn or the matchstick spots, it is found in the peritoneum of pouch of Douglas. The space, in that space you can see the matchstick appearance, then you confirm it to be pelvic endometriosis. Again, double confirmation, biopsy confirmation of excised lesion is ideal. Differential diagnosis of endometriosis. Chronic pelvic infection is most often confused with symptomatic endometriosis. So, the dyspareunia, dysmenorrhea, infertility, these three symptoms of the endometriosis are going to confuse us with chronic pelvic infection. The clinical presentation is almost similar. Laparoscopy is helpful in actual diagnosis. So, to differentiate whether it is chronic pelvic infection or the endometriosis, we get a laparoscopy done. During laparoscopy, you can see the matchstick appearance. You can get the biopsy done. And then you can confirm it whether it is a chronic pelvic infection or endometriosis. So the differential diagnosis will be chronic pelvic infection. Chocolate cyst. The ovary is the most common site of endometriosis. It starts with a superficial endometriotic implant over the ovarian surface. So we have already discussed that the most common site of endometriosis is ovary. How does it start? With the superficial endometriotic implant. On the ovary, superficial endometriotic implant will be there. Then the cyst formation is due to the periodic shedding and bleeding from the implant. First, what happens? The endometriotic tissue is going to be implanted, and then what happens? There will be this endometric tissue, it is going to implant in the surface, then periodic shedding. Then what happens? Every cycle the hormones estrogen is going to act, and then what happens? There is shedding. This is going to shed. When the cyst ruptures, the characteristic thick tarry fluid chocolate material escapes. When it is shedding, you can see the chocolate material. When it starts a shedding cycle, estrogen is acting, then there is shedding, there is growth of the ectopic site, and then there is shedding. The chocolate material escapes. This is known as chocolate cyst. This is the differential diagnosis. Now we'll see the other differential diagnosis is rupture of the chocolate cyst during the operation while separating the adhesions, like if there is uterine fibroid or the endometriotic tissue which is located in the peritoneum, and other adhesions, pelvic adhesions. While separating the adhesions of the endometriosis, the cyst invariably ruptures. You were separating some other thing, but the cyst is invariably rupturing with the escape of the chocolate colored blood. The rupture of the cyst can occur spontaneously, that is by itself, causing the acute abdomen with clinical features suggestive of acute ectopic. So, the clinical features of acute ectopic will be presented which can be confused with endometriosis. Acute abdomen is confused with torsion or rupture of the ovarian tumor, disturbed ectopic pregnancy, appendicitis or diverticulitis. Let us summarize it again. Acute abdomen, it is confirmed with the torsion or the rupture of ovarian tumor, disturbed ectopic pregnancy, appendicitis or diverticulitis. Now let us move on to the complications of endometriosis. What all the complications can happen if a person is having endometriosis? Endocrinopathy. This may be mostly responsible for infertility. These things happen, endocrinopathy, and the person may land up into infertility. Corpus luteum insufficiency. So guys, whenever there is an abnormal formation of the ovarian follicles, that will result in corpus luteum insufficiency. So the ovarian follicles are not forming properly. That will result in corpus luteum insufficiency. Luteolysis due to increased prostaglandin factor 2 alpha. Luteolysis. What is luteolysis? When there is rupture of the luteinizing hormone, it is because of the increased prostaglandin factor. Luteinized unruptured follicle, there is no rupture of the follicle, it undergoes luteinization. Luteinization is nothing but when the Graafian follicle is transforming into the corpus luteum, that is known as luteinizing. When there is unruptured luteinizing follicle, guys, the follicle needs to be ruptured. When it is not rupturing, there is luteinization of the unruptured follicle,